Hi, everyone. My name is Martin Köring. I'm a managing editor and also the global healthcare lead at the Economist Intelligence Unit's thought leadership practice. I'd like to welcome you to today's webinar, sponsored by Pfizer, on behavioral economics in healthcare. And this is such an important topic. You can participate in the debate by sending your questions on the website. There is an orange button on the bottom right corner with an Ask Question sign. So please participate. If you have a question, you can ask in general or to a particular panelist as well. So today's webinar is about behavioral economics in healthcare. We know the benefits and the medical and cost-saving benefits of preventative healthcare measures, diet, exercise regimes, vaccinations, medical screenings. However, patients often choose not to adopt these preventative measures. Instead, they often base their decisions on emotional, psychological factors, emotional responses, cognitive biases, these kind of things. These often have an outsized influence in contrast to evidence, facts, figures, and these kind of things. So this virtual event is anchored in the findings of a report that the Economist Intelligence Unit has written that will be published on the same website where the webinar is taking place. That will be freely available there, so please come back to the website later on in the next couple of days to download the report. It's freely available. It's also on the EIU Perspectives website. So the findings of this report feed into the webinar. And our panel of experts that we have invited will explore some of the topics that were raised in the report. So we look at, for example, exploring some of the methods to narrow the gap between theory and practice, looking at what kind of interventions work, why and how do we leverage these kind of interventions to reduce the burden of disease, how can policymakers use these findings to design more effective health campaigns, how healthcare professionals can use these findings to better engage with patients around preventative healthcare, and what kind of support they need to be able to do this. So we'll discuss these topics for about 60 minutes. We have 4 speakers. And obviously, please participate in the online tool as well to ask your questions. And the webinar will be available as a video later on after it has been recorded. So please come back to the website as well. So first of all, I would like to introduce the distinguished panel. So first of all, we have Hugo Harper, who is the principal advisor at the Behavioral Insights team. And then we have Manuel Linares, who is the president and founder of Fundación EO. Then we have Wolfgang Philipp, who is the head of unit, the Crisis Management, Preparedness and Health team at the European Commission. And then we have Pauline Patterson, who is the co-director of the Vaccine Confidence Project. So the way we've structured this webinar is, first of all, we'll have a little bit of a scene-setting discussions about what behavioral science and behavioral economics is and what kind of influence it has in healthcare. Then we'll look a little bit at the demographic factors that have a role in decision-making in healthcare matters. And then we look a little bit at the personal experience and emotions and these kind of triggers in healthcare decision-making. We look at cognitive biases, and hopefully we'll also have some time to look at how to change the environment in which decisions are made to really support preventative healthcare. And finally, hopefully we'll have some time to look at the way forward, what kind of collaborative approaches we can create to really use the findings from behavioral science to support better decision-making in healthcare. So first of all, in terms of setting the scene for the discussion, what is behavioral science? What role does it play in healthcare? The premise for the research that we have done and that is published in the report was that decisions on preventative care, from simple safety steps, for example, wearing seat belts, to more elaborate diet and exercise regimes, vaccinations, medical screenings, these kind of preventative measures are typically subject to a variety of psychological influences. Among these can be emotional triggers, advice from friends and family, for example, advertising campaigns, consumers' personal experiences with a particular disease. These decisions are also subject to a variety of cognitive biases as well. And behavioral science and also behavioral economics in particular, and this is kind of a method of economic analysis that applies psychological insights into human behavior to explain human decision-making, economic decision-making, can really play an important role in understanding healthcare-related decisions. So by way of kind of setting the scene, I would like to ask the panel, what role can behavioral science and behavioral economics play in public health and also in healthcare, including healthcare policy making. So I'd like to start with Hugo, please.
Thanks. I mean, I think behavioural science or behavioural economics is incredibly important to a realistic understanding of human behaviour. So that's to say, it gives us an idea of how people actually behave in practice rather than how they sort of should behave in practice. And preventative healthcare is a clear example of this, right? There are things that people perhaps should be doing that they're not doing. And so how can we understand how they're making the decisions, what's driving their decisions, and how can we make it easier for them to make these decisions in the future, the things that will benefit their health in the longer term?
And Wolfgang?
Just to add on this, I mean, from a EU perspective, when developing new policies or, for example, also in the past campaigns, behavioral insights is a very much welcomed element that triggers and drives and adds up to traditional assumptions, which are usually evidence-based. So bringing in evidence from a new field into comprehensive policy making is very much welcome, and it's also part of the standard mechanisms that we use nowadays. At the end of the day, of course, it is not just about developing policies and having all elements contributing to it, but it's a matter of really understanding of what I want to reach with a policy and how to implement it. So therefore, these insights are very much welcome and very important.
And from the vaccine background, what kind of insights can behavioral science play?
So while most people vaccinate, some people choose to delay or refuse vaccines. And it's key to identify susceptible populations that aren't vaccinating to then understand the barriers and the facilitators to vaccination, and then to be able to tailor the immunization program.
And Manuel, you work a lot in the infectious diseases space. So what is your view on behavioral science and behavioral economics?
Yes, I'm going to introduce a marketing concept, user experience, and how is our design. So sometimes it's so different that people can do what we want. So I work in like a general practitioner. My idea is to change with best practice for the government and institution to improve that.
Great. So now we have a little bit of better understanding what behavioral science is and what kind of role it plays in healthcare. Let's maybe move into some of the more specific factors that actually influence healthcare decision making. So maybe first of all, let's look at demographic factors. Despite the widely recognized benefit of preventive healthcare measures, consumers often fail to embrace them. And we've mentioned that, leading to higher than necessary rates of illness, and we addressed it in our report as well. Demographic factors play an important role in this. They often play a crucial, really, to influence the propensity to take preventative measures. For example, we addressed it in the report, higher socioeconomic levels are correlated with greater use of preventative healthcare measures. Moreover, some of the studies that we mentioned in the report as well indicate that women are more likely than men in similar age and income brackets to take preventive care measures. Age as well is also positively correlated with greater use of preventative measures. So I'd like to ask the panel, how can health policymakers and healthcare providers better take account of these demographic factors when devising preventative healthcare programs and also when consulting with patients? So Hugo?
So I'd like to start with the demographic factor you mentioned of socioeconomic status. I think this is really important, something that comes up time and time again as one of the places where the effect seems to be largest, and also where we can care the most about it, right? We're looking to reduce health inequalities, we're looking to reduce the gap between the richest and the poorest in society. And when we're considering this, we need to think about the situations that they find themselves in. So yes, there's a financial element to it. It might cost some sort of money to undertake some of these preventive measures, but there's also a cognitive bandwidth element. So this is a concept that's been familiarized called scarcity, in the sense that when you're in a stressful environment, when you're worrying about, if you're going to have enough food on the table tomorrow or how you're going to pay the bills at the end of the week, you might not be considering things that are in the long term. You might be focusing in on your immediate concerns that leaves little time to think about things like preventative healthcare. And in order to better reach these sorts of demographic groups, we need to be thinking about their environment, the environment they find themselves in, the other stresses, the emotions that are occurring, and tailoring the programs to make it as easy as possible for them to engage in these preventative behaviors, rather than just providing them information or sort of telling them this is what you should be doing.
And from the vaccine background, have you come across these kind of demographic factors, and how do they influence decision making, and what can you do about that?
So to add to Hugo's points, convenience is one of the determinants of vaccine hesitancy, of the reasons why people might not vaccinate in terms of access. So access to the vaccine, access to the clinic, cost, time. We did a study with Public Health England, applying the WHO tailoring immunisation programme tool, looking at a Jewish Orthodox community in northern London, trying to understand, there had been a measles outbreak a few years ago, trying to understand why some parents chose not to vaccinate their children. And the average number of children in this community is 7. So if you've got 7 children, just remembering which vaccine is due for which child when, and the waiting times in the GPs are overstretched. So sometimes you have to wait 2 hours for vaccination to happen. It's a long time. Or the clinic's far away, or it's on a day that's inconvenient. So access is key in vaccination.
And in terms of infectious diseases, have you seen similar demographic factors playing a role?
For example, I work in a very depressed area in Madrid, so we have programs for screening HIV, hepatitis. Sometimes it's difficult. For example, in hepatitis, we have a cure, we have a treatment now these days, and we can do the screening if we don't go out of our clinic. So we have to work hand by hand with the people, with the patient, with the NGOs in the system, with the institutions. So demographics is very important in our daily. Like a general practitioner, primary care is the main door of the system.
Very good point. And also from the EU point of view, have you come across these demographic factors that influence decision making in terms of crisis response, being prepared for crises?
I mean, that's in crisis response, of course, it plays a role. But I mean, even if it sounds trivial, there is no sociological homogeneous group that you're addressing with policies. So that is a major factor you have to take up before you start thinking about designing programs that go to the ground, but also before coming up with policies that address, for example, at the EU level, member states of the European Union. Here you have a certain meta level, but nevertheless, taking into account these demographic factors is a key element, because you want to have activities, or you want to propose activities or actions that really reach the right people. Coming to Pauline's point on vaccination, seasonal influenza vaccination is a factor is important for the younger and for the elderly. HPV vaccination is ideally done in a certain age group as well. Preventive measures like access to healthy food, or fruit school schemes and so on and so forth, that addresses, of course, only certain demographic groups, distinct groups. So it's a key element in designing policies, of course.
So we've heard demographic factors play a crucial role in healthcare-related decision-making. If you want to participate in the conversation, if you want to ask a couple of questions, then please feel free to do so. There is an orange button on the right bottom corner of the website where you can ask your questions, and we hopefully will be able to address those. Let's now move on to the next kind of category of influences in terms of healthcare decision making, and those are the personal experiences and emotions. So beyond demographics, personal experience of a particular illness, for example, is positively correlated with propensity to take preventive care measures. So if someone has already experienced a disease from their family, from themselves, they're more likely then to take preventative measures. Emotions also influence people's decisions on preventative care. For example, in our study, we also mentioned that social psychologists have shown that people tend to focus on short-term rather than long-term outcomes of their behaviors. For example, they assign more importance to the short-term benefits of painkillers, for example, than the long-term risk of developing addiction. And also individuals tend to assign great weight to the views of family and friends, for example, when they make decisions on medical matters. So how can health policymakers and health providers better take account of these personal and emotional factors when devising preventative healthcare programs, and also when consulting with patients? Hugo?
Well, these things are incredibly important. So to your first point of your experience of something. So we often refer to this as something called the availability heuristic. So it's rare that people will bother looking up the real numbers on something. So you'll sort of have a guess about what the danger of something is. So a sort of silly example of this is people are a lot more scared about shark attacks than they are about dying in road traffic accidents, where one is much more likely than the other. And so the availability, the experience people have had with these things might, in a sense, cloud their judgment. They might be not thinking about the real numbers. So at a first point of call, it's important to provide the real information about things, but that's still probably not going to be enough. This long-term, short-term trade-off that you mentioned, it's the idea that benefits in the future, we care about a lot less than benefits in the here and now. And, there's some sense to that, right? You might not make it to 50. But if you do, these are things, the preventative healthcare measures that you could have taken now might make your life a lot better. And so it's how can we bring the benefits into the forefront of people's minds? How can we make it clear for them, or at least make the difficulty of the action seem further away? So it seems easier in the here and now for people. And I think the other point you mentioned around the emotive response to things, and an important point here is a concept called psychological reactance. So this is the idea that if information is deemed too negative, too sort of serious for people, they might react against it. And in sort of a soft version of this, they'll just ignore the information. They'll just stop paying any attention to you. And in the harder version of this, it can even backfire. So there's some evidence that this can happen with sun cream adverts. If you go really hard and say, these are all the terrible things that will happen to you if you don't put on sun cream, people can react against it and sometimes even put on less sun cream. And it's these quirks or biases of human decision-making, these emotive responses, that we need a really good understanding of if we're going to design effective preventative healthcare policy.
Did you have examples of such a kind of initiative or policy that has addressed these personal emotional kind of barriers?
Yeah, so there's a program that we run with Public Health England and DrinkAware. So DrinkAware are a charity that look into responsible drinking. And we looked at whether more traditional messaging around the health impact of over-consuming alcohol were more effective than perhaps a more novel approach of using appearance-based messaging. Now, as you might be aware, appearance-based effects are likely to happen much, much quicker than the long-term health impacts of alcohol consumption. So there's an intrinsic trade-off in terms of the long-term, short-term, and also what people might relate to more immediately, what they might have a more emotive response to. And what we found was that this appearance-based messaging, talking about the negative effects that alcohol can have on your appearance, was actually more effective at getting people who were coming to the website to take a self-monitoring drinking test. So to measure the amount that they were drinking, and the idea is to find out whether they're at risk or not. And the really interesting thing about this, which speaks back to the previous point on demographics, is that this effect was entirely driven by women. So there was no difference between the health and appearance-based messaging for men, but the effect was entirely driven by women. And you could imagine in the future tailoring those sorts of campaigns to better give the information that, one, speaks to people's maybe short-term preferences, and two, takes account of their demographics when you're providing people with information that's relevant.
Okay, that's really interesting. And also maybe Pauline, on the kind of the vaccination side of things, I mean, already we've heard a couple of examples of, how personal experience and emotions play a role. And what do you see in the vaccination space in terms of these influence and how to address them?
So in terms of availability, visibility, vaccines are a victim of their own success. So, for example, if you don't see a disease, you might think that you're not at risk of that disease. And then I wanted to add, in terms of the concerns around now or concerns around the future, HPV vaccine is a great example of this, that the human papillomavirus vaccine, its main aim is to prevent cervical cancer, which is many years down the line. And so there might be less risk perception around the disease. In terms of information sources, when we carry out studies to understand why people aren't vaccinating, we look at who the vaccine decision maker is. So if it's a parent or an individual for themselves or their mother, and who's influential, who they listen to, where they go for information, if they go online, if they go on social media, who they talk to. And then also we found that facts, it's very important in communicating facts, but also stories work very well, and they go for people's emotions. And then finally, in addressing misconceptions, so in addressing concerns around, for example, side effects, scientific research in psychology has shown it's very difficult to do. If you if you mention a myth, it might make people think, even if you say that it's a myth, people might read it and then come out and go, ooh, they might have a higher risk perception. And also if you use strong language, then readers will have a higher risk perception. So you have to be very careful.
Many interesting points. Maybe Manuel, do you want to add anything in terms of your work on infectious disease?
Yes, I believe in that the digital innovation for patient business, for example, Google, Facebook, or Amazon, knows more than your doctor from you. So why don't we take that tools for our daily practice? So it's very important. For example, only 1 in 10 travelers go to doctor to get in advice. So why? Because they are reading ground information on the network. So how is the e-patient? No? How we change that? So we have to very close to that to now make different point of view.
And from the EU point of view, from how the European Commission, for example, can address these kind of personal experience, emotional influences on decision making in your work on crisis response and preparedness, have you come across these factors?
I mean, in a basic or perhaps a trivial way, of course, emotions are driving decisions. So that's the basic trigger. That's the basic trigger you have to take into account. So that is a very important element that behavioral economics or behavioral insights has brought into EU policy making in general. I mean, if you look now, just a couple of examples how emotions are used. One could be the latest Stop Smoking campaign financed by the Commission, where footballers from FC Barcelona were used to trigger emotions, basically, and to get kids and teenagers and other people as well, older people as well, into cessation of smoking. Another good example, of course, of behavioral insights policy making is using the plain packaging and these shocking pictures on cigarette packages. That has a clear effect on the emotions, and thus shows how using emotions can trigger also the implementation of policies on the ground where it should reach the people at the end of the day. And I'm coming back here now to the discussion we had on the demographic groups. Of course, at the end of the day, to reach people at risk and to create the best possible preventive, but also health outcomes.
I mean, we have a question here that is relevant on the demographics. Earlier, you mentioned the Drink Aware program, Hugo, in terms of the differences of how men and women react to these kind of campaigns. So one question we have here is, are there any differences in relevant approaches towards behaviors among men and women? So we have already that example, but is there anything? I mean, maybe in vaccination, is there a difference in approaches?
So we find that in general, men tend to be viewed as riskier. And so in some of our other work, we found that slightly stricter messages, ones around being ones that appeal to your own sort of self-interest, tend to work a little bit better than for men, whereas perhaps unsurprisingly more cooperative or sort of social good-based messages tend to work a little bit better for women. I think these effects are small, though. I think the difference is there. It's important when you're looking at population levels, but there are much more similarities than there are differences with these things, and I think it's important to remember that.
I think the key thing is also the context. It's really important. It's not necessarily the demographics, it's the context that these people are in, their environment, what's going on around them, their social pressures, all of that.
Okay. Great. All right, let's move on, because time, of course, is flying, to the next category of influence on healthcare decisions, the cognitive bias. And actually, we have already addressed some of them. What are cognitive bias? I mean, for example, the tendency to take no action under conditions of uncertainty, a tendency to avoid making decisions when confronted with too many options. These kind of cognitive bias tend to reduce the likelihood of taking preventative care measures. A different type of cognitive bias, the nocebo effect, can arise in individuals exposed to information of a negative nature about a particular drug or remedy. We discussed like sun creams earlier. So we have already addressed some of these points. This exposure then to this information can lead to self-fulfilling prophecies of experiencing the same negative side effects, for example. But how can policymakers and healthcare professionals address these kind of cognitive barriers to preventative care?
So I think these cognitive barriers are really important. And again, it comes back to how do people really make decisions? So these biases often come out of heuristics that people use. So these are sort of mental shortcuts. And these tend to be used in situations where you have a lot on your mind, where you're under what's called cognitive load. And that can be sort of a general stressful situation. And it could be also if you're having a lot of negative experiences currently. And I think what's important to remember with these examples is that we need to take account of the potential backfires of them. So you mentioned this nocebo effect, and this speaks again to this availability point that we mentioned earlier. So yes, it is important to tell people the potential side effects of something, but you can start misattributing things, right? If you think about if something says that it might cause muscular pain, well, I don't take any medication, I have muscular pain on a reasonably regular basis anyway, and I might start attributing that to the wrong thing. And so we need to have sort of a fair balance of how realistic something is actually likely to be, rather than sort of going really strong with negative potential negative side effects of things.
And Pauline?
So we see omission bias, we see that with vaccination, where, for example, a parent would feel more guilty should they choose to vaccinate their child and there was a negative side effect, compared to if they choose not to vaccinate and their child gets a vaccine-preventable disease. And as long as this set of parents are not fearing the vaccines, then it's worth kind of rebalancing that with facts of saying that actually the benefits of the vaccine weigh up against the risks of vaccinating.
And your work on infectious diseases?
I find a new profile in my practice that is people that don't know that they don't know. So it's very interesting to work with them because they get the information, grown information, and we have to change the emotionality and how doctors show our information. So that's, you don't know that you don't know. That's very interesting.
We have a question here on that follows on from the discussion we had. What are some tools that can be used to identify these cognitive barriers? Have you come across some tools?
So we've been my team's been working in behavioural science for a long time now, and most of our interaction comes with policymakers. So how can you get across the many complexities of behavioural science, relatively young discipline, without sort of a unified theory, whilst still making it easy for people to really understand the key points? And we've developed something called the EAST framework. So this is mnemonic, and it stands for making things easy, attractive, social, and timely. And so I think easy we've already discussed. Attractive is around sort of getting information that is personalized to you and you sort of care about, that is salient, that's easy to read. Social speaks to the network effects that you mentioned earlier. You care about what your peers are doing, what the people around you, your family or loved ones are doing. And you also care more generally about what the population is doing. If 90% of people are doing something, you're more likely to want to do it as well. And lastly, timely, giving people the information at a time they can actually do something about it. So for example, giving somebody information about the calorie content of a burger. If I tell you now, the chance of you remembering it by lunch tomorrow, in a week's time, it's very little. So you need to provide information or reminders to people at a useful time for them. So we found this framework relatively helpful when people who don't have a background in behavioural science sort of thinking, well, what can I do about these things? So that's making things easy, attractive, social, and timely.
That's a very good framework to look at this. Anything from the EU side, of any tools you have?
Particular tools, I would say, overcoming or really tackling cognitive biases is the essence of working in prevention, at least in the health area. This is the basis of it. Coming back to your burgers, I was recently in Canada and I saw something that, you look at me, I also like to eat these things, but I know about the calorie intake. And I was standing in front of one of these shops and they have they have the calorie figures behind the different formulas, and I turned around and went away to eat something different. So that is a good, I think, a good practical example of showing how you can overcome these cognitive biases. On the other hand, what you also mentioned already, information overload. That is something we have to be very careful about, not just in terms of amount of information, but also where it comes from. Vaccination, good example. And the other point is from where does the information come? So I don't know if it's if Dr. Google is the best address, or if it's at the end of the day your GP, but the GP has to be informed, of course, and have objective and non-biased information available for you. So I think these cognitive biases, that is really why we all still have a job, and why we are working in these fields, trying to improve the access to vaccination, the uptake of vaccination, healthy nutrition, and so on and so forth. Also dealing with infectious diseases. There is no good reason not to take your medication regime, for example, if you're on a TB treatment. There is no good reason for it. Still, people are doing it, and I think that requires a lot of work. It requires that this is taken up at all levels of policy making, and it is considered seriously. And I think the HIV movement, at the end of the day, and I don't want to overstretch my time here, but I think the whole HIV movement, the whole elements that were developed there in terms of prevention, that goes back to addressing cognitive biases, including emotions. So the 2 points that we have been talking about already. I want to stop here.
Yes, many great points. And before we move on to the next category of the topics in terms of how can we change the environment, there's one question on the earlier demographic angle that we looked at. Is there evidence of how educational attainment or joblessness impacts on preventative healthcare initiatives? Is there anything? We looked at some of these differences in terms of socioeconomic differences. In terms of education, in terms of unemployment, does that play a role?
So there's certainly something to consider in terms of presenting information in a way that's really clear for people to understand. So if I'm talking about what's your cardiovascular disease risk, I'm talking about that over a 10-year time horizon, and I'm giving that to you in percentage terms, that might not be very intuitive for lots of people, particularly if they've had sort of lower education levels. And so it's important that when you're putting that information out there, that it's accurate, but that it's understandable. And sometimes you need to lose a little bit of the detail, or present different levels of detail as optional to people. But the thing to consider as the first port of call is, will my core target audience understand this? And I think it can be very easy for policymakers, when surrounded by the environments that they are and by the peers who they work with, to forget about sort of the different levels of educational attainment that in terms of the populations you're trying to influence, and really to try and keep this in mind when you're designing any information.
Great.
It's difficult to answer that because my last 3 diagnoses in HIV was university people. So it's supposed that they know perfectly how they transmit the disease. So we have to analyze the different axes of the patient and social network. We have to analyze the analytics of where they look for information.
Something I think it's worth mentioning on this is a lot of psychology experiments are done on university undergrads. They're done on people at universities, and so some of the findings might not translate to people, sort of real people, if you like, in the field, or what the majority of the population's experiences. And this is why it's really important to make sure you're testing out any of these insights. So there's lots of great ideas, and they can come from psychology, from behavioural economics, from anthropology, but it's making sure that we're rigorously testing these in the field, in sort of the real environment in which people are operating, to make sure they're having the positive effect that we hope they will.
I have a project in that sense because the new society needs results at the moment. So the rapid test at primary care, so get results and solve the problems to the people in the moment. So, but that you need a lot of money for them to do that, yes, of course.
There's one question here, and again, feel free to ask questions. There's the orange button on the right side of the screen. There's one that is focusing a little bit more on vaccination. What are some tactical tools that healthcare practitioners can use with their patients that can tackle some of these biases and misconceptions around preventative measures, including vaccination?
So that's a great question. Thank you. what we found is that vaccinated healthcare providers are more likely to recommend vaccination. And also, if healthcare providers recommend vaccination, people are more likely to vaccinate. What we suggest is that it's important to acknowledge concerns, so not to brush off any concerns. So if a parent or a patient comes to you with concerns around a vaccine, not to say, your evidence is rubbish, or, well, you don't worry about that. It's very important to acknowledge and to engage. So to engage with the patient, I know sometimes there's limited time, but to have a conversation. Listen, but also recommend vaccination.
Okay, great points. So maybe let's move on to the next category, because we're kind of running out of time. So in terms of changing the environment, we've already talked a little bit about the importance of the environment in which decisions are made and how to influence that environment. So the research we have done has shown that changing the environment in which decisions are made or not made can have a huge impact on health outcomes. So for example, we looked at some case studies, community-based weight loss programs, for example, in France, and workplace-based healthy eating programs in Ireland, show that changing the environment in which individuals make these kind of health-related decisions ultimately can be more effective than just plying them with large amounts of information. So how can we create a more conducive environment for patients and health consumers to make decisions that have better health outcomes?
So to go on with the current example around sort of healthy eating or obesity initiatives, this is incredibly important because you make eating decisions multiple times every single day. And so the idea that you could keep sort of a set of health information at the front of your mind for all of that time is just ridiculous. And so we need to make sure that our environments are conducive to healthy choices. And I think it's fair to say at the moment, in most places, they're not. So you're bombarded with lots of advertisements, with price promotions for things, buy one, get one frees, for things at the end of the aisles, right by the checkouts. And so what can we do to maybe limit the excessive availability of these things? So not to restrict people from being able to buy them, but just not having them right in your face the entire time. And so an example that we ran of this was with a hospital in Australia. We took the high sugar drinks and we put them in a cabinet where you couldn't see. So very similar to tobacco control. And so anyone who wanted them could ask for them still. But what we saw was there was no drop in sales, but the vast, vast majority of people just shifted to the diet drinks. And this, particularly in food, people have reasonably fuzzy preferences. So by that, I mean, people might state a preference for something, but really it's quite marginal. They wouldn't really mind sort of the healthier version. And so can we put the healthier version of things at the forefront of people's attention, make it as easy as possible for them to go with that option rather than the less healthy one, and then take the burden away from the member of the public, from the consumer. So rather than saying, you need to do this, you need to take account of this at all times, have an environment that makes it the easy option for them, makes the healthier choice the easy choice.
Great points. I mean, maybe Manuel, in terms of working in a healthcare environment, what are the kind of environments that I mean, how can you change the environment with your patients, for example?
The global health is the answer, perhaps, and primary care like the main door. Yes, we have to work together with the vets, with the agriculture, with the pharmacies, with everybody, and we have to go out from our comfort zone because it's easy to go to work every day and sitting in your chair, patient. No, we have to go out because things happen outside. And patients are not in the hospital, patients are in the field. So we have to work in the field. And general practitioners do that. Yes, we have to trust in them.
I mean, maybe there's one question that fits nicely here because you were talking about global health. And one question is, how does policy approaches differ for developed and developing countries? I mean, at the moment we have a lot of examples from developed country situations, but is there a difference?
A lot of difference. I just arrived from Cameroon these days, and they don't have primary care then. So people die by strokes every day, a lot of diabetes. No program to at this moment in many places. So we have to learn how to teach what we have done here, because it's the time to change things in developing countries.
And in terms of vaccination, have you seen, I mean, just in general in terms of changing the environment, but also in terms of changing the environment in different contexts?
So what we've seen, so for vaccine concerns vary by time, by location, by context, by country. So it's key to understand all of those factors. I really like the EASE model, so easy, attractive, social, timely. We have confidence, complacency and convenience, a 3C model of vaccine hesitancy. So confidence in terms of level of trust in the vaccine, but trust in the provider as well, trust in the policy. Complacency, so this lack of perceived need, value for the vaccine. Convenience, the access to the vaccine we were discussing before. So it's key to identify the reasons for vaccine hesitancy in order to address those.
And in terms of what the EU can do in terms of changing environments, and maybe also in terms of, I mean, you work across the EU, of course, but are there differences across countries and how to address these?
There's huge differences across countries. First of all, in terms of, or considerable differences concerning health outcomes in certain specific areas. I mean, time is too short to run into these details, but also in terms of vaccine coverage and vaccine uptake, in terms of antimicrobial resistance rates, and so on and so forth. So I think from a policy perspective, talking about changing environments, there's a two-way road here. One towards the kind, let's say the end user or the person, the citizen, and on the other side also to change the environments in terms of policy making at a policy making level. So a good example here is, for example, the EU Action Plan on Antimicrobial Resistance of last year, which has a very clear and very focused One Health approach. We transpose this and we try to develop this also in our preparedness work and also in the crisis response work to have all angles available and addressed. But at the end of the day, a conducive environment is always focused. That is an important point, and you have to start with a good understanding of what kind of behavior you want to influence and trigger. So I think therefore the right incentives are very important, not just for the end users, but also for the policymakers. Simply to come up with a proposal which is based on evidence, including, of course, at least after our discussion of today, including, of course, behavioral insights.
Great points. And maybe before we move on to the final part of the webinar, there's a question here that, I mean, we talked about different contexts and with the decisions are made. One question is on, are there any indications or studies on how health and well-being programs and initiatives at workplaces may have a special impact on health and views on healthcare promotion and prevention?
So most of the good studies I'm aware of this come from America, where there's sort of the incentive as lots of workplaces pay for people's healthcare, and so they've got a very clear incentive to try to improve the health of their workers. I think there have been some of the examples are kind of similar to the canteen examples we were talking about earlier. So can you provide a healthy eating environment for places? They also have some incentive schemes that have been around physical activity. And I think one of the important aspects of these is trying to bring out a sense of social ties in these things. So, you know, something having just individuals versus individuals might not work as well as, let's say, marketing versus accounting. Putting people into teams so they feel a social responsibility in order to do these things and giving them timely feedback. We've run some studies in Australia looking to encourage physical activity in this way. And the really nice thing about this is all of the effect was seen at the lower quartiles. So the people who were exercising the least before the trial, that's where we saw the biggest gains. The people who were at the top of the distribution, who arguably there's very little benefit in running 20K a week rather than 10K a week, we didn't see any change for those people. And so we were really pleased with that result.
That's great. So many interesting insights.
Yeah, I have an example. So in terms of strategies to improve influenza vaccination in healthcare providers, strategies that have been found to be effective are having a free vaccine that's accessible. So if you have a mobile cart, so the vaccine comes to the healthcare provider rather than healthcare provider having to go to the right hospital at the right time in the right department type thing. Educational activities also work, but as with reminders, incentives. So some studies that were done in the US showed that if you give a free voucher for the canteen, or there was even there was a prize for a holiday. So you had a kind of tombola type thing. And if you vaccinated, you had the chance of winning a holiday, which I thought was a bit excessive. But opt-outs or mandatory immunization policies. So some hospitals enforce influenza vaccination, or if you don't vaccinate, then you need to wear masks, and it says like, I wear this mask to protect you, although that's a bit of shaming, so I'm not sure that's a great strategy. But peer vaccination also works well. If you know, if it's a colleague who's actually running the campaign, you're more likely to vaccinate, or if you know that your boss is vaccinated, you're more likely to vaccinate.
Many great points. I mean, we have to move on, unfortunately, to the next category, which is basically the final category, kind of discussing what is the way forward now that we have all these insights from behavioral science and economics, especially in terms of collaborative approach. I mean, we have different kind of people here that are experts in their respective fields, and already this is a sign of collaboration. But what are the collaborative approaches we really should adopt, to make progress in terms of having behavioral science insights really playing a role in terms of encouraging more preventative measures? So our research shows that the collaborative approach, based on shared decision-making and a focus on the positive results of taking preventative measures, is more likely to inspire the use of preventative care than one-way communication or berating people for bad behavior. So how can we inspire this kind of better cooperation between healthcare professionals and patients, but also between healthcare professionals and other stakeholders, such as policymakers, for example? Would you like to start?
Global strategy is the best practice. For example, in my case, I've launched several projects in screening of infectious disease, and it works. And the politics and institutions have to take them because we are diagnosing a lot of people with infectious disease, and we are treating and cure some of them. So, and this have to be digital too, because the patients use Google a lot, and doctors are not in Google sometimes. So, for example, with travelers, they have bad, the drugs for anti-malaria have a bad press because they read the bloggers for travelers, and blog travelers doesn't like the prophylaxis of malaria. So we have to change the model in different ways, working with the schools, with associations, with institutions, with industry, with many actors in this.
So you can apply very similar insights that we've been talking about earlier, so easy, attractive, social and timely, to collaboration as well. So how can you make it as easy as possible for institutions to collaborate with each other, and how can you align incentives for it? And to pick up on another point that you raised, giving people sufficient time in order to do something. So what can we do to automate other processes to mean that the sort of crucial clinician contact time is being made the most of? And can we give even clinicians guides at the point of that interaction? And lastly, the point is to keep testing things. It's still a new area, and having solid evidence, preferably with using randomized control trials, about the impacts of these sorts of approaches will further facilitate its adoption. So if you need to prove that you need to spend an extra few minutes with a patient, or you need to have a conversation in a certain less clinical area, you will be fighting for your finances in order to do that. And in order to make that case effectively, you need to have a robust result proving the benefits of this approach.
And Pauline?
Thank you. Well, you can't solve a problem you don't understand. So it's very important to understand the issues, understand what you need to do. And collaboration is key to learn from each other. But collaboration between us, patients, the public, religious leaders, community leaders, healthcare providers, policymakers, key.
Great. And in terms of the collaboration between, for example, the EU and healthcare decision makers and patients, how can these kind of collaborative approaches be developed?
I think, at least at the EU level, there's, of course, policymaking is done in a collaborative approach always, because it affects 28 member states at the moment. I want to come back on one point, which is, of course, research in this area here should be strengthened. The Commission, for example, has a Behavioural Insights Lab. They're working on policy testing, mainstreaming, and eventually on policy promotion of these elements into policies where it makes sense. A better cooperation can always make sense. I mean, that does not mean sitting together and talking, but sitting together and looking at the evidence that is provided through these areas, and then also to take up ideas and elements which are developed and which are tested. Also at a larger scale, ideally, to take them up also in cost-benefit and assessments, which are run before certain programs are either established or not established. So these would be the angles I would see.
Okay, great. Still have a little bit of time. There's one question on, we addressed only the time horizon, which is sometimes a really important element in decision making. And one question here is about, do you feel that most preventative health initiatives require significant cultural attitude shifts? If yes, what is the typical time frame that these shifts take place? Are they generational, for example?
I think this is something I often fight against a little bit. I think the idea that you need to change people's beliefs and their attitudes and then that will change their behaviour, I think is slightly overplayed. A lot of these behaviours people want to engage in if it was costless to them. And by that I mean truly costless, if it happened instantly and required no hassle. And so rather than perhaps giving them more information to try and raise their thinking about how important something is, can we lower the barriers to uptake of these and to just make it as easy as possible for people? And that will have a positive effect, right? These idea of social norms, that sort of what is culture, is what a lot of people are interested in what they do. If you can increase the number of people who are engaging this behaviour, that should have a positive knock-on effect, whereby individuals then observe that behaviour happening more in their community, they feel it's more appropriate for them, and then that actually changes their beliefs about the importance of the behaviour in itself. So it's sort of coming at it from slightly a different direction.
Any other views on cultural shifts? How we can...
About the future, no?
Yeah.
Medicine is going to change in next years more than a century before. So what's the next medicine we are going to do? Perhaps patients are going to direct the medicine. So a lot of changes in the future, because if we control the data, and the data is possible to give you diagnosis better than a doctor sometimes. Like, there is a joke that is Watson, the IBM computer reads 1 million books in a second, and I'm still in the 78th page. So, so this is the future. This is the future, and we have to use the data, and the health professionals have to be inside, because we are a step beside now.
Anything else on cultural shifts?
I agree with what Hugo was saying, is I don't think we need a cultural shift. I think we need to understand the reasons why in vaccination, understand why people aren't vaccinating, and most of it is access.
Same here. There's no need for a cultural shift. There's a need for good options and for good offers, which are targeted and which are taken up. I think it's not a matter of overcomplicating things and starting to think about artificial intelligence, self-learning systems, including a little citizen somewhere. That is not going to work. I think the offers must be there. The offers must be in a way targeted and also realistic or smart, as you would say.
There's one question here on government policy initiatives. Population media has been successful in changing cultural norms, biases through radio and television, media storylines in developing countries. Are there more examples of government policy initiatives?
So my current favourite government policy initiative is the sugar tax in the UK, so the soft drink industry levy. And this is a really interesting from a behavioural perspective, as it targets reformulation of products. So yes, it does provide financial incentives to try to reduce the overconsumption of sugary drinks, but those incentives are directed at the producers. And what that does is force them an incentive to reformulate their products. And we've already seen incredibly good results for this in the UK. And why this is important, it means the can of drink that you bought yesterday, that you bought from the same shop at the same time, you buy it tomorrow, and maybe it's got a little less sugar in. And what's really nice about this is it requires no additional behaviour from the consumer. And why this is important is because there was already a huge variation in the amount of sugar in these drinks that consumers couldn't tell the difference between. So there were certain sort of brands of lemonade that had either 11 grams or 6 grams or 4 grams of sugar. People can't really tell the difference. So can you make these changes? Can you have these policies that change people's environment for them? But importantly, don't make it any more difficult for them to do the healthy behaviour. And ideally, as is this case, don't reduce the pleasure of their consumption either. It's a real sort of win-win in terms of policy initiative.
Great example. anything in the vaccination space where you have like an example of a government policy initiative?
So there are some countries in Europe that have decided to mandate vaccination in order to increase coverage, but I'm not necessarily sure that's the right way about it. It depends. If the reason that coverage is low is because there's an access issue, and by mandating it, then you're increasing access, then perhaps, but I don't think that coverage, I think it's important to sustain and to build trust and to understand why people aren't vaccinating and solve those issues.
Just to add on this, of course, I mean it's a matter of a member state or of a region or whoever decides on how these vaccination programs look like at the end of the day. But I think it's at the end of the day it's a matter of right incentives to get vaccinated, because that's what we want to see, at least from a public health perspective. So behavioral insights here will play certainly a huge role in terms of defining such incentives that make people think at least and take a cognitive decision about why or not to vaccinate. Although we all hope that the decision is in the sense of being vaccinated, at least for the trivial preventable diseases.
Do you have any examples of government policies? You have recently been traveling, as you said.
Yes, for example, the trust in policies government. We have to give a clean message sometimes. You buy a car that is contaminated and you don't know, for example. You have problem with that. The dual message we have sent before. Like health professionals have to do our personal branding. So we have to show the people we are clean. We are not selling nothing. We are only looking for health. That's the message. That's very good for developed countries.
So we're kind of running out of time, but maybe just by way of concluding, or just like to ask each of you, maybe if you have like one insight or one key change that has to happen to really have behavioral science, behavioral economics become kind of a tool or a way of really promoting better preventative care measures. If there's like one change or one shift, then that would be great to highlight.
I think it's the adoption of this approach within government policy, within the profession and within different departments. We've seen this in the UK. So my team originated in the Cabinet Office, and now there are several departments that have their own sort of sub-teams. And these look at using findings from behavioural science to policy. And it's essential that policymakers have easy access to this information. It's not good enough to tell them to go and read 100 journal articles about this stuff. They need to have readily access to experts, and these can form internal teams. It can also form collaborations with academic institutions. So something that's a good example of this is policy research units in the UK, how to bring the experts from academia and behavioural scientists within academia into the policymaking sphere, rather than telling policymakers that they have to read up on it all themselves.
Great points. Volker?
I think at the EU level is more or less the same. In any case, behavioral insights inform policymaking at the EU. There is since a couple of years the so-called better regulation, and it's one part of the toolbox that you need to go through if you start planning new policies.
Great. Yeah. Pauline?
Thank you. Healthcare providers remain the most trusted advisor and influencer of vaccination decisions. However, they're stretched and in terms of addressing confidence. And so we need to ensure that they have the tools and the training.
Great. And Mona?
5 points. Access to information, bidirectional interaction, natural language, multi-channel. We have to be multi-channel, and emotion. Get your emotion. That's my key points.
Thank you very much. We have run out of time, but I'd really like to thank you for these great insights and these great views. I mean, obviously, hopefully, they will have an impact, and also working together to find solutions to actually have behavioral science and behavioral economics as a tool or a way of kind of looking at things differently to have potentially better outcomes and better preventative care measures. So I'd like to thank you first of all, but also I'd like to thank the audience for these great questions. There have been lots of really interesting questions. We couldn't address all of them, of course, but the conversation continues. We'll have the webinar video will be available online on the same website. And obviously the report will be published in the next couple of days. So there's a lot of continued conversations about this. So thank you very much. And I'd also like to thank Pfizer for sponsoring and also the Economist events team for putting this webinar together. Thank you very much.